Otitis Media. Middle ear infections are one of the most common reasons children present for medical care and receive antibiotics. In the United States, otitis media was the second most common reason antibiotics were prescribed in 2010. National guidelines from many countries provide separate guidance for managing otitis media with effusion and acute otitis media. However, differentiating between these two syndromes, which often exist on a continuum, takes skill and practice. Developing this skill set is critical to incorporating stewardship principles into your practice. Distinguishing between these clinical scenarios and following widely accepted guidelines will reduce the inappropriate use of antimicrobials, thus diminishing the selective pressure that allows for the emergence of antimicrobial resistance. In addition, 4 to 10% of children treated with antibiotics for a middle ear syndrome experience an adverse reaction, some of which could be avoided by closer attention to the appropriate use of antibiotics. In this module, we will discuss the highlights of several national guidelines for the management of acute otitis media and apply them to common clinical scenarios. We will not discuss the management of chronic or recurrent otitis media. While important, an in-depth discussion of accurate otoscopic examination is beyond the scope of this module, so please refer to the references section to find further learning opportunities for you to improve this crucial skill. Let's begin this module with a case. Imagine you are in clinic and are evaluating an 18-month-old girl with 3 days of fever and frequent awakening at night. Her mother reports she's been pulling at her left ear for the last 48 hours and crying. Her mother reports the child has been alert, has not had any vomiting or diarrhea, and also reports frequent wet diapers and good oral intake. Several family members are ill at home with nasal congestion, and the baby had rhinorrhea for 3 to 4 days prior to the onset of fever. She has received her immunizations on time, including vaccination against pneumococcus. Of note, her father smokes in the home. On physical examination, she is febrile to 39 degrees Celsius, and all other vital signs are normal. She is alert and appears uncomfortable, but is non-toxic in appearance. Pneumatic otoscopic examination reveals fluid in her middle ear. In addition, her left tympanic membrane is red, opaque, bulging, and immobile. How would you manage this patient? Acute otitis media most commonly occurs in children 6 to 24 months of age, with declining prevalence as children reach school age. Acute otitis media is uncommon in adolescents and adults. A viral upper respiratory tract infection leading to eustachian tube dysfunction is thought to cause the middle ear abnormalities we are discussing in this module. The eustachian tube is a narrow canal that connects the middle ear to the nasopharynx, allowing for pressure normalization. However, inflammatory edema narrows this canal, leading to increased pressure within the middle ear and allowing for the accumulation of fluid. Pathogens causing the upper respiratory tract infection and those colonizing the nasopharynx then gain access to this fluid and the middle ear, causing acute inflammation. Fluid within the middle ear is present in both acute otitis media and otitis media with effusion. The difference between these two clinical syndromes is the evidence of inflammation on physical examination. Acute otitis media is the acute syndrome of middle ear fluid with evidence of inflammation. Otitis media with effusion is defined as the presence of middle ear fluid without evidence of acute inflammation. It can be acute or chronic and may occur before and/or after an episode of acute otitis media. In fact, middle ear effusions may persist for weeks to months after an episode of acute otitis media and is not an indication of treatment failure. Although they recognize there is no gold standard for the diagnosis of acute otitis media, The 2013 guidelines from the American Academy of Pediatrics emphasize the importance of physical exam findings in their recommendation. These guidelines apply to children 6 months to 12 years of age. They recommend that acute otitis media only be diagnosed if a middle ear effusion is present. They advocate for clinicians to diagnose acute otitis media in children with middle ear effusions who also meet one of the following criteria which suggest inflammation: moderate to severe bulging of the tympanic membrane, new otorrhea, usually considered less than 48 hours of duration, without evidence of otitis externa, suggesting perforation of the tympanic membrane, mild bulging of the tympanic membrane and recent otolgia within the last 48 hours, mild bulging of the tympanic membrane and intense tympanic membrane erythema. Most national guidelines stress the importance of a tympanic membrane appearance when diagnosing acute otitis media. The management of acute otitis media is complicated since antibiotics most often provide little benefit. Most cases of acute otitis media resolve without any intervention and without complications. A Cochrane review of 13 randomized controlled trials found that antibiotics were not helpful for the majority of included patients. This review demonstrated that antibiotics shortened the duration of otolgia by 1 to 2 days, but there was no difference in symptoms at 3 to 7 days. Antibiotics did not decrease recurrence of acute otitis media or prevent hearing loss, although they did modestly reduce the risk of tympanic membrane perforation. This review also estimated that for every 14 children with acute otitis media exposed to antibiotics, 1 develops an adverse event such as diarrhea, vomiting, or rash. Based upon the fact that many causes of otitis media resolve without intervention and the significance of adverse events, many national guidelines, especially in developing countries, promote withholding antibiotics in some cases of non-severe acute otitis media. In the past, some of these uncomplicated or non-severe cases received antibiotics in order to prevent rare and severe complications associated with acute otitis media. However, the number of patients that need to be treated in order to prevent these complications is unacceptably high. For example, studies estimate that 4,800 children would need to be treated to prevent 1 case of mastoiditis. The 2013 American Academy of Pediatrics guidelines recommend using antimicrobials in the following scenarios: severe otitis media, including moderate to severe otolgia lasting for greater than 48 hours, or fever greater than 39 degrees Celsius. This includes those with bilateral or unilateral disease. They also support the use of antimicrobials for patients with non-severe bilateral acute otitis media in children less than 24 months of age. The guidelines recommend clinicians consider observation with close follow-up based upon shared decision-making with parents for children's ages 6 to 24 months with non-severe unilateral acute otitis media and for children greater than 24 months of age with non-severe unilateral or bilateral acute otitis media. Current NICE guidelines recommend delayed or immediate antibiotics for patients who are children of any age with tympanic membrane perforation or otorrhea in their ear canal. They also recommend antibiotics for children less than 2 years of age with one of the following: bilateral acute otitis media, bulging tympanic membranes, or an acute otitis media severity of symptom score of greater than 8. The AOM-SOS is a validated questionnaire that can be used to interview parents and assess the severity of their child's symptoms. This questionnaire consists of 7 questions depicted here and include an assessment of behaviors suggestive of pain, including ear tugging, crying, irritability, difficulty sleeping, playfulness, and ability to eat. Each answer of a little contributes 1 point to the composite score. An answer of a lot contributes 2 points. Per NICE recommendations, a cumulative score of greater than 8 should prompt the consideration of antibiotics in children who are less than 2 years of age. The NICE guidance also emphasized the need to optimize analgesics for all patients and recommend observation with close follow-up for patients who do not meet any of the criteria listed in the slide preceding this one. Let's return to our case and address the patient and epidemiologic factors introduced in the basic modules. First, how severe is this patient's condition? This baby, who is alert and tolerating oral feeds, does not require hospitalization. What is the likely source of this infection, and what are the likely pathogens? You diagnose acute otitis media. Her physical examination is notable for classic findings of relatively severe acute otitis media. She has evidence of a middle ear effusion and middle ear inflammation with bulging, erythematous, and immobile tympanic membrane. According to the 2013 American Academy of Pediatric Guidelines, she qualifies for antibiotic therapy given her diagnosis of acute otitis media and the presence of fever. She also qualifies for antibiotic therapy according to NICE guidance, given her age, bulging tympanic membrane, and severe symptoms. Gauging the severity of otolgia in preverbal children is difficult and subjective. According to American guidelines, she also qualifies for antibiotics given the duration of otolgia, assuming the ear tugging and excessive crying are signs of pain in this preverbal baby. Other symptoms commonly accepted as signs of otolgia in preverbal children are rubbing or holding their ears and sleep disturbance. The most common bacterial pathogens associated with acute otitis media include Streptococcus pneumoniae, non-typable Haemophilus influenzae, and Moraxella catarrhalis. Vaccination rates, including pneumococcal vaccination, impacts the relative prevalence of these organisms. However, studies have also isolated many different respiratory viral pathogens. Co-infection with viral and bacterial pathogens is also common. How likely is this infection due to a drug-resistant organism? Although the prevalence of drug resistance among Streptococcus pneumoniae is growing worldwide, this has not impacted the prevalence or severity of acute otitis media. Most guidelines recommend high-dose amoxicillin as the first-line therapy in patients who have not received antibiotics within the last 30 days, who do not have concomitant purulent conjunctivitis, and who have no history of recurrent acute otitis media. What other patient characteristics must be considered? The most important issue in administering medications to children is to accurately dose by weight and ensure that parents know what to do if a patient vomits or spits up a dose. You refer to relevant national guidelines and prescribe amoxicillin at a dose of 90 milligrams per kilogram divided into 2 doses, with a maximum of 3 grams administered per day. The 2013 American Guidelines recommend different durations of therapy depending on a patient's age, as listed in this table here. The NICE guidance recommends 5 days of therapy for all patients with acute otitis media. However, a recent large randomized controlled trial of children aged 6 to 23 months with acute otitis media found that patients treated with amoxicillin clavulinate for 5 days were more likely to have clinical failure than those treated for 10 days. Further revisions of recommended treatment durations are likely to emerge in clinical practice guidelines in the future. You also provide pain relief, a key recommendation from most national guidelines. You counsel her patients regarding the risk of secondhand smoke and urge them to quit smoking. You also encourage the entire family to get their yearly influenza vaccinations if this is in line with your current guidelines. Let's move on to case 2. Imagine now you are in clinic and evaluating a 2.5-year-old boy with 2 days of pulling at his left ear. His mother reports he has been alert, has not been crying, denies any vomiting or diarrhea, and reports frequent wet diapers and good oral intake. Several family members are ill at home with nasal congestion, and the baby had rhinorrhea for 3 to 4 days before he started pulling at his ear. He has received his immunizations on time, including vaccination against pneumococcus. Of note, his father smokes in the home. On physical examination, he is afebrile, alert, and all other vital signs are normal. Upon pneumatic otoscopic examination, his left tympanic membrane is light pink, semi-opaque, and immobile. It is mildly bulging. How would you manage this patient? A reasonable approach would be watchful waiting. This patient's most likely diagnosis is non-severe acute otitis media. His only symptom is ear pulling, and he has no severe signs on examination. According to the guidelines, this patient is a candidate for observation or watchful waiting without starting antibiotics. In fact, a recent review noted that watchful waiting for mild to moderate acute otitis media is standard of care in national guidelines for many countries, including the US, Italy, Japan, South Africa, Australia, Sri Lanka, Argentina, and Moldova. The applicability of this strategy depends on the availability of follow-up. Also referred to as the observation option, this strategy includes deferring antibacterial therapy for 48 to 72 hours while providing symptomatic relief. Importantly, this strategy must be paired with a follow-up plan or means for easy communication between the parent and clinician if the patient worsens. This may consist of a follow-up appointment in 2 to 3 days that can be canceled if the patient does well, or a delayed antibiotic prescription that can be filled if the patient worsens or her symptoms are not better in 2 to 3 days. Studies in different nations have employed this strategy of watchful waiting and have shown that only 1/3 of these patients ultimately receive antibiotics, sparing the majority of patients from the potential consequences of antibiotic use. Of note, watchful waiting may not apply to immunocompromised children or those with craniofacial abnormalities. Let's return to case 2. You tell your patient's mother that her son has fluid behind his ear that does not look severely infected. You tell her that studies show that many patients like her son do well without antibiotics. You describe the criteria for antibiotic use outlined in national guidelines and point out the signs and symptoms that her son thankfully does not have. You detail the number of potential consequences of antibiotic use, including the chance that her son may not tolerate the medication and develop an adverse event. You suggest a strategy of watchful waiting, describing the warning signs that she must watch out for, and provide suggestions regarding appropriate pain relief. You offer a follow-up appointment in 2 days in case her son's symptoms worsen. Initially, the patient's mother is hesitant regarding this plan since her older son received antibiotics for a similar presentation when he was little. But she remembers the diarrhea he developed, which she thought was due to the antibiotic. She is grateful for your thorough explanation and agrees with watchful waiting. Again, you counsel regarding the risk of secondhand smoke and urge the father to quit smoking. You also encourage yearly influenza vaccination as appropriate. Clinical evidence indicates that many patients with otitis media do well without antibiotics, and evidence-based guidelines are available to help clinicians make management decisions. Thus, acute otitis media provides an excellent opportunity for clinicians to incorporate stewardship strategies in their daily practice. These principles include accurately diagnosing acute otitis media, prescribing antibiotics in accordance with national guidelines, employing watchful waiting appropriately, and including analgesics in your therapeutic plan, and encouraging preventive measures, including vaccination and tobacco cessation. Routinely following these principles will improve the quality of care you provide your patients and promote the appropriate use of antimicrobials.